Right.
Saju, എന്തൊക്കെയുണ്ട്?
സുഖം തന്നെ.
ഏതായാലും നിങ്ങൾ 3 സ്പീക്കേഴ്സ് ഇപ്പോൾ ഉണ്ട്. ഡോക്ടർ ജോയ് ഉണ്ട്, ജോസ് കൂട്ടൂരങ്ങളുണ്ട്.
Oh, Saju, I accidentally stopped the video on accident. So.
Did I?
I did.
Okay.
And then if you could, yeah, that was it. So I'm gonna share my screen again to take control.
Sounds good.
Hi, Sanjay.
Hello, Saju, how are you?
Okay.
Enough snow on the other side of town?
I feel like I'm the only guy on the jacket, so I'll take my jacket off, which is great.
No, go easy with that.
No. I have one too. Then I thought, make it semi-formal. So.
Yeah, that's good. That's good. Make me feel good. Can you see me? I can't see myself, but.
No, it looks like your video is hidden. We can ask to start your video.
Yeah,
oh, there you go.
There you
Perfect.
Go.
Great. So now that we've got our 3 speakers on, like we had talked about in our last conversation, we're going to do about 10 minutes per speaker. Dr. John is going to speak first, and then Jos Kottoor, and then Saju, you'll speak. And after that, we're going to open it up to Q&A. So you guys have submitted your questions, and we'll go through those. And depending on what the audience looks like, how many people we've got, we'll be able to go through as many as that we can. And we've got some questions prepared on the back end as well. But we'll wait probably a few minutes to see who joins at 6 o'clock, see how many people we've got. And, if it's a conversation between just us group that's here right now, we'll go with that. And that's okay. Hopefully we'll have some more people, but if not, then, hopefully we've got a nice crowd, and we'll wait to see how it goes.
Hey, Diana, I didn't give a question out, didn't get a chance to, but I can shoot something out, or do you want me to email something out, or?
Yeah, if you want to just send it privately in the chat to me, that's fine. We can go that way. And then one thing that Dr. John was talking about was, when we open up the Q&A to the 3 of you, you 3 can ask yourselves questions as well. So if you've got some questions that you think would be relevant that one of the other 2 can answer, then go ahead and do it that way too.
Yeah, okay.
So we're going to wait a few minutes, but when each of you are done with your segments, if you can kindly say, okay, Diana, I'm going to throw it back to you. And then that will be an indicator to me to be able to continue on with the flow and move it from there.
Good.
All right, so there's some people in the waiting room, so that's good.
Oh, okay.
Yeah, I'd keep them waiting for a few minutes.
Yep.
Yeah, sure. At least let somebody in.
Well, then if let's all go on mute then. If anybody has any other questions, maybe then, if we're good to go, then let's turn our sound and video off.
Actually, I can do that. I'll make it so that everybody will be muted, and then you can unmute yourself. Okay.
Okay. And then Sean, we'll talk via the chat to.
Yep. Sounds good.
Indicate the start.
All right. So 5, 4, 3, 2, 1.
Good evening, everybody. On behalf of the Debate Club of Detroit, I welcome you all to a live discussion on universal healthcare in the US, the pros and cons. My name is Diana Chereville, and I will be moderating today's event, and we are so happy to have you all join us. Before we get started, I'd like to introduce you to somebody who has spent a lot of time putting together this great event for you. He's going to share more about our topic and why this came to be. So please help me in welcoming Mr. Jamon Jacob.
Thank you, Diana. So I extend a very warm welcome to each and every one of you who is watching this program through live on Zoom and also on YouTube Live. So this is a Debate Club of Detroit's 1-year anniversary program. So I just want to go through a few things. What is Debate Club of Detroit stand for, and what is the goals? What is we like to achieve through all these programs? So like about 1.5 years ago, we started this program to promote public speaking, trying to develop a harmony and a friendship among us through open discussion, through sharing our thoughts, through thought exchanges, to improve youth leadership, to improve the civil representation among us, especially in the, if possible, in the government sector, government participation, and to provide a lifelong learning experience among us. So we live in an era of misinformation and disinformation. So misinformation is somebody is giving an information without, they are not planning to give us a bad information without their knowledge. Say, for example, you are going to a bank, you are asking a bank employee, are you open on Saturday? That person may be a new employee. They don't know what is the real hours for Saturday. So they are telling you that, okay, we are open on Saturday until the evening, but that's wrong. Disinformation is somebody is giving you an information which wants you deliberately giving a wrong information. This is not a new thing. This has happened for many years. I want to take you a moment to take you all to the time of the great scientist Galileo. He was living in the 16th century. He is, as we all know, he is the one who proposed the heliocentrism. Until that time, or historically, all the people were thinking that Earth is the center of the universe, and the sun and other planets revolve around the Earth. So he proposed this idea. He came up with the idea that, especially on solar system, sun is the center, and the Earth and other planets revolved around the sun. He had very resistance among the people to take these ideas. There was a back and forth debates among the scholars and elderly, among the rulers. But so there was a lot of questions among the public. There was thought exchanges. There was heated discussions. Even this era, all this happens. So Debate Club of Detroit is not standing for any special propaganda. We are only here for a platform to discuss various subjects we choose among us. So this time we choose the topic universal healthcare in the US, the pros and cons. And we brought the experts in that particular field, our 3 keynote speakers, Dr. John Mathews, Sri Kottoor, Sri Saju George. I welcome all the 3 keynote speakers to this. Also, we have the 3 pillars of support for this program from the very beginning. Sri Thomas Kartanal, Sri Mathews Cheruval, Srimati Mary Sebastian. I welcome all of you along with the technical crew to this program. I conclude my words with this quote about the history. The famous quote says that whoever do not know the history is likely to repeat the history. I repeat, whoever do not know the history is going to repeat the history. So it's always good to know what's behind certain things and exchange the ideas rather than being unrealistic. I welcome all the suggestions and feedback from each and every one of you for our future programs and topics. And I wish you all a nice and interesting listening and discussion program. Thank you. Back to Diana.
Thank you, Jamon. As you can see, the Debate Club of Detroit is such an important environment for people in our community to be able to learn, debate, exchange, and grow. And tonight, as you've been able to hear, we have a great event ahead of us, and I really look forward to getting into it. But before we get started, I want to give you a few housekeeping tips. First, each speaker that we hear tonight is going to present for about 10 minutes. After our third speaker concludes, we're going to open it up for Q&A for everybody, and we're going to take as many questions as we have and can in the time that we have allotted. In between each of our speakers' presentations, please kindly keep your audio muted and your video off until it's time for the Q&A session. And lastly, just so you know, we are going to be recording today's session so that we can use it for future use down the line. So if you're going to be on camera, go ahead and bring your best face. As mentioned, we will have time for Q&A tonight. You can either type your question into the chat box, or if you'd like, you can ask it live. To ask a live question, what you'll do is click on the participants icon at the bottom of your screen. Then you'll be able to click the raise your hand button. When it's your turn, we will invite you to ask your question. You'll see two requests. One is to unmute your audio, and the other is to turn on your video. Once you go ahead and do both of those things, you'll be able to ask your question live. And even though Q&A is not until all the speakers conclude, feel free to send your thoughts into the chat box anyway, because we will be monitoring that. Our first speaker today is Dr. John Mathews. Dr. Mathews is a medical oncologist at the Windsor Regional Cancer Center. He's also the assistant professor at the Schulich School of Medicine and an adjunct professor at the University of Windsor. So clearly he has lots of free time. Tonight, he's going to share about what exactly universal healthcare is and its background. And because he's based in Canada, we'll be able to hear his perspective on that. So I welcome and hope you all welcome as well, Dr. Mathews.
Do you have to stop your share screening for me to come on?
No, you should be able to do it, but I'll stop it anyways. Go ahead. Is it not working?
Everyone, thanks for coming to attend the debate or our presentation. And my role is to just give a bit of historical background of the universal healthcare, as well as give you an idea of how things are in Canada. And I won't get too much into the US system as such. So when you look at universal healthcare, it is defined as a system where a country or region have access to healthcare, which is assured, and it is irrespective of one's ability to pay or afford. So in many countries in the world, they are done in different methods. Some places.
Dr. Mathews, I'm sorry,
Yeah.
this is Diana. We can't see your screen. Can you go ahead and click that share screen button once again?
Oh, sorry.
No problem.
Dr. Mathews, if you're having trouble, I can just share mine as the backup if you
Yeah,
prefer.
sure, you can go
Yeah?
ahead.
Okay, okay. Just give me 1 second. All right, can you guys see it?
Can they see it?
Yep, I think so.
Okay, yeah.
Yep.
Yeah.
Okay.
Yeah, can I have the next slide? Yeah.
Yeah, sure.
Yeah, so basically, universal healthcare is a system where a country or region have assured access to healthcare, irrespective of the ability to pay or afford. So this system is different in different countries. In some countries, it's government funded. In some countries, everyone has to buy private health insurance. In that system, if people cannot afford, the government would subsidize it. And basically the goals of doing it this way is to obtain the highest possible level of care for all people, regardless of any discriminating factors. Next slide. So if you go through the history, way back over 150 years or so ago, in Germany, they started it as a sickness insurance law, where employers had to provide coverage for employees. And in that system, only about a third of the population was covered. Subsequently, in Russia in the 1920s, there was an attempt to cover the population about the healthcare, but it could not cover rural population. But getting into the 1930s, 40s, many countries began having universal healthcare of different varieties, initially in New Zealand, Australia, and subsequently around 1948 in UK. Now in Canada, all this happened between 1950s, 60s, and 70s. So by early 70s is when most of the country had this system. Next slide, please. Now, there are different ways to obtain universal healthcare. In certain countries, it's a single payer system. So in example, in UK and Spain, the revenues come from tax, and it's all, the hospitals, doctors are all funded from that. And they are basically almost like working for the system straight away. Then another way of doing it is social health insurance model, where everyone has to buy insurance, some through employers, some on their own. And if people can't afford on their own, then there'll be a government subsidy kind of. So that's the social health insurance model. And the third one is like a national health insurance. Like example, Canada, Taiwan, South Korea, where there is a public insurance which is funded mainly through taxes, but it's provided by private care. Like people are, the doctors would build the system or the labs would build the system. That's how it happens in Canada. Next slide, please. So this is just a cartoon to, people say that US healthcare is very costly. So, I don't know if everybody agrees it, but, when you go to the next screen, there is a comparison. So this is a comparison between certain countries. So if you compare like Australia, Canada, all the way to the US, one way of comparing it would be the percentage of GDP. So in the US, it's about 18% of GDP, whereas most of the other countries are like 9 to 11% of GDP spent on healthcare. But in Singapore, it's way low, but then they have a two-tier system. Certain systems are single-tier, means everybody is covered. Others are like, they might be private as well as a government system. So when you look at absolute dollars converted to US dollars, the US system approximately, I would think, costs about $10,000 per person per year, whereas the other systems are about $4,000 to $5,000 per person per year. Now, obviously, there is the disadvantage also that, in the publicly funded system, there is more of a wait time. So it's very tough to get things within a day or two unless it's medically urgent. So other way to compare it is the outcome. So if you look at the last two columns, if you look at, say, infant mortality rate, and say, try compare it across the countries, countries that are doing the publicly funded system are not doing poorly. They are, in fact, some of the countries are doing much better. Same way, if you look at the life expectancy, when you look at different countries, I would say that they still have a very high life expectancy, despite people having to wait for things and all that. So could I have the next slide, please? So I'm focusing my next half of my discussion on the Canadian healthcare system. Initially, in Canada, the provinces are quite independent and they have a lot of powers. So the federal government can only do so much. The provinces have to all come on board. So when the public healthcare began, it started in certain provinces and took a number of years to come all across Canada. So initially, it started in Saskatchewan in the 1960s, and then subsequently, it was almost like early 80s by the time it reached the rest of Canada. So there was a Medicare Act in 1966, which laid the groundwork for it. And then subsequently, there's Canada Health Act. Can I have the next slide, please? So the 5 principles in the Canada Health Act are, one is public administration. So these plans are all administered by the government. So it's not a private insurance company running it. So the administrative costs are very low, and in the vicinity of 2% is the estimate. Second principle is it's comprehensive. So it covers most of the necessary services, hospitals, medical practitioners, and everything, though what I mentioned later on, some things are not covered. The third one, it's universality, so that it should cover the whole population or most of the population. Then the next principle is the accessibility, that all insured people must be able to access services when they medically need it without having any financial hardships. And the last one is the portability. So in Canada, when you travel from one province to another, the insurance is covered whichever province you visit, and there is no extra payment or anything. So irrespective of what each province pays their own people, when you go to another province, you get medical care from that province. And next slide, please. So in Canadian healthcare, it's basically the provincial responsibility to deliver. So this is funded by tax. Some provinces ask people to make some monthly payment, annual payment to fund it, but it's predominantly by tax, and all the residents are covered. It's administered and run by provinces, but the federal government pays about 50% of the cost. And one of the important rules is that the doctors or care providers cannot bill any extra money for the covered services. So the doctors have a choice to be in the public system, but once they are in there, they cannot charge more for from what the government is paying. Could I have the next slide, please? So what is covered for free in Canada? When you look at it, doctors' visits, consultations, you don't have to pay anything. Lab tests are covered. Diagnostic imaging, X-rays, ultrasound, and various types of scans are covered. Emergency room visits or care are covered. Dialysis is covered. Cancer treatments within hospitals or cancer departments are all covered. Could I have the next slide, please? As far as what is not covered, it does not cover the cost of prescription drugs which are taken as an outpatient. Exceptions are in children and people who are older than 65. It also covers people who are on social supports, disability, and things like that. But for the general working population, they have to buy their private insurance or have it through their company or employer, or they have to pay on their own. Now, there is a little bit of subsidy from, say, a province like Ontario. They have something called Trillium Plan, so that if you don't have any insurance and you are less than 65 and you're in that age group, you can apply for the Trillium Plan. And if your cost is more than 4% of your household income, they will pay the rest of the care, the cost of the medications. But then the first 4% of your family income will be like a deductible. Similarly, physiotherapy is not covered. Dental care is not covered. Some people have private insurance that cover all these other things: prescription drugs, vision, dental care, extended health travel, and things like that. Could I have the next slide, please? Now, what are the advantages is that most of all the costs are covered. And the advantage is that you can travel from one province to the other and it's all covered. Now, if timely care is not available in where you live, they would refer you out of province or out of country, but these services need prior approval. So if you have a particular thing that you need in Windsor that cannot be provided in a timely manner, you can get it from the closest place you want. So the main advantage is that urgent and serious issues get attended to rapidly, irrespective of cost and without any co-payment. Can I go to the next slide, please? The disadvantages is the family doctor is the main gatekeeper of the system, so that for any questions, you have to first see the family doctor, even if you need specialized care. Then if they think it's necessary, then they have to refer you to the specialist, like cardiologist or whatever. You cannot walk in or go directly or approach a specialist. So that is discouraged in the system. So the second thing is expensive investigations are limited. So that if you want a CAT scan and an MRI and a PET scan on everybody, it's very tough to do it. You'll have to justify. For the PET scan, which is probably the costliest of our recent investigations, if you need it, there are very specific guidelines and you have to follow that. And if you want one off guideline, you have to write and get pre-approval before you have it done. And then again, urgent surgical procedures get done as priority, but elective surgical procedures, they would be waiting. Next slide, please. So institutions, you have hospitals, emergency room, they're all government organizations. Doctors' offices are mostly private, some are solo, some function in groups. Labs predominantly are private. Some are within the hospitals, but they're very few. Pharmacies are mostly private with very few exceptions. And nursing homes can be a mixture of private or public. Certain things are not covered. Now, most of the health, what I described so far, is covered by the province. Now, the federal government only covers very selected healthcare issues. One is armed forces, is almost like your VA plan, then natives, then federal penitentiary, people who are refugee claimants, they are all covered in a federal plan. International students and visitors, they should have their own private coverage. Similarly, short-term workers should also have their own private coverage. Could I have the next slide, please? So that's all I had. Thanks for listening. And I hand you back to Diana. Thank you.
Dr. Mathews, thank you so much for helping lay the groundwork for this conversation. And if you've not really known too much about universal healthcare, I think that we're beginning to really start to paint the color around this topic. As a reminder, Q&A will be after each of our three speakers conclude. And so if you have any questions, though, feel free to put them into the chat box and we'll be monitoring that. Now, we are going to move on to our second speaker, Mr. Jos Kottoor. Mr. Kottoor is the Chief Executive Officer at the Lake Huron Medical Center, and he brings with him nearly 20 years of hospital administration experience. Prior to his CEO role, he served as Vice President of Operations and Chief Operations Officer for Beaumont Hospital in Wayne, Michigan. He was responsible for the oversight of a 185-bed, full-service acute care hospital. Today, Mr. Kottoor is going to speak on the pros of universal health care in the United States. So please help me in welcoming Mr. Jos Kottoor.
Thank you, Diana. Sean, can you hear me?
Yeah, I can hear you.
Okay.
Are you going to share your screen?
Yeah. Yes. All right. Okay. Is that my screen? Can everybody see that?
Yep.
All right. Thank you, Diana, for that nice introduction. I just want to thank the Detroit Debate Club for organizing this program. The topic is very relevant during this pandemic, especially, when we are actually dealing with the healthcare when the healthcare is an issue in everybody's mind. Special thanks to Jaimon Jacob for leading these efforts, and thanks, Diana, for moderating, and Sean for the technical support. I want to reiterate the fact that my presentation is going to be just about 5 points: history and evolution, how the U.S. healthcare is funded, and how U.S. healthcare is provided, and benefit of the U.S. healthcare, and a conclusion. As Jaimon was talking about, whoever do not know the history is going to repeat the history. So I want to kind of, briefly talk about the history of the U.S. healthcare. So let me go to the next slide. Let me see. Okay, here we go. So, when you are actually talking about the U.S. healthcare system, the Civil War actually propelled the, healthcare in the U.S. at a fast track, because it actually involved a lot of injuries, a lot of issues related to pandemic, a lot of issues related to other, diseases and infections and things like that. So Civil War actually really, put that healthcare progress in a fast track. Then also, U.S. healthcare is based on the staunch belief that it is in capitalism, and there was a historical opposition to socialized medicine. So when you look at all the history of U.S. healthcare, you could actually see over and over again whenever there is a proposal for socialized medicine, there was opposition from the public and also from the providers who are the physicians in the community. Then in US healthcare, women also played an important role, especially during childbirth. During childbirth, mortality was higher. Then also there was also issues related to communicable diseases. So during the initial migration in the 1700s, there was actually a lot of women actually were midwives, and they were the ones who were taking care of the issues related to childbirth. Then in the mid 1800s, during Civil War, more soldiers die from communicable diseases. So that way they have to, address those issues also during that time. Then, as we all know that, especially when there is trauma, war facilitated the surgical techniques and advanced research and nursing methods and care for people who are injured. Most of in US, from the long time back, when as long as early as the colonization, healthcare was provided for fee for services. So fee for services means when you are actually provided care, people pay for that particular service in cash or dollar amounts or things like that. So in the 1900s, the Industrial Revolution also happened. Then Ted Roosevelt, who was the president, believed in universal health care because he felt that no country could be strong whose people are sick and poor. So he actually initiated the healthcare discussions about how do we provide healthcare for the workers or the working class and also for low-income citizens. But the American Medical Association was concerned about the way the doctors were compensated, and they opposed it very strongly. So that the initiative from Ted Roosevelt did not actually happen. But during the First World War, Congress passed a War Risk Insurance Act, which actually covered the military servicemen in the event of death or injury. That was the first time Congress has actually passed some type of a healthcare plan for the people of United States. Then in 1923, Baylor Hospital in Dallas started a health insurance for teachers for a monthly fee. This program quickly caught on, and this was actually the first time there was a employer-sponsored insurance program for the community members or the employees. This was also taken over or was sponsored by the nonprofit organization called Blue Cross and Blue Shield in the United States. Then in the 1930s, during the Great Depression of the 1930s, healthcare for the elderly and unemployed became challenging. Then again, Roosevelt advocated for the national health insurance for older Americans because, again, from the opposition from the American Medical Association, this was actually being tabled. Then at that time, Roosevelt again created a Social Security Act for the retirees and elderlies because he strongly believed that some type of a support need to be provided for the elderly and the poor. Then in the 1930s, again, during the Henry Kaiser, who was an industrialist, who provided the prepaid health insurance for about 6,500 employees in order for him to recruit and retain employees for his business. So that was actually really the second time then a provider or an employer was actually providing insurance for their employees. So in the 1940s to 1940s, again, slowly the employer-sponsored healthcare continued, primarily from a perspective of there was hard to recruit employees to their businesses. So there was a pool of employees and certain employers were competing to do that, competing to attract these employees to their employer. So people were actually making it more attractive for the employees, providing them with healthcare so that way they will come and work for them. So they started the employer-sponsored health insurance in the 1940s. But again, so it was actually only targeted for the employees who are healthy, but again, then the veterans, disabled, and the poor were left without any kind of insurances. So in the 1960s, while John F. Kennedy was the president, he actually initiated discussions about national health care, but again, it was opposed by the American medical insurance because of the fear of a socialized medicine program. Then after John Kennedy was assassinated, Lyndon Johnson expanded in 1965 the Social Security Act and Hill-Burton program in order to provide health insurance for seniors and disabled citizens to make sure that they have the affordable health care. But again, this also, he got the support from the AMA, primarily from a perspective that he made sure that these insurance are actually provided through hospitals and physicians. So this bill actually laid the foundation for Medicare and Medicaid. So there was also several attempts to expand healthcare from 1965 since Lyndon Johnson was implemented this act. But again, the Act of 2010, the Affordable Care Act, was passed by President Obama. So that way, that actually increased the coverage for health insurance in the United States. Now, I want to kind of give you an idea about how people are insured in United States. So the U.S. population, there is the, overall, there is two groups actually. So then there is the one group is called the insured. That again, the insured group is actually then insured and uninsured people. So the insured group, you could actually see that one is through public insurance, which are the Medicaid, Medicare, and other public. That means that if it is children's, so there is a children's health insurance plan, then there is also other public insurances. Then there is the private insurance plan, which is provided by employers. Then also independently, people could actually get, insurances. Then there is also exchanges like ACA, Affordable Care Act. So those are the ways you actually get the insurance. Then when you look at the next slide, it is, if you look at the United States as a together, in the 2019, that period when the ACA was prevalent, about 8% of the US population was uninsured, but about 92% of the people had insurance. So then if you look at any private plan, there is about 68% of the people are insured through private plan, and about 34% are insured through public plan. So when you look at the private plan insurances, the employee-based, the plan is actually provided for about 56% of that 68%. So then there is also the direct purchase, and also then there is the TRICARE, which is actually the insurance for military and armed forces. So then there is the public plan, which is covers about 34% of the US population, which Medicare provides about 18%, and about the 17% is provided for about Medicaid. Medicaid is the state-sponsored plan. Then there is also the VA and CHAMP program, which is about 1% of the population. So then if you look at how do we spend it? When Dr. John was talking about the expenses, it's about, when you look at our US population, it comes to about 17% of the GDP. So that comes around 2.7 trillion in healthcare. So in this, when you look at that, how does that money come from? So this is actually about 20% is coming from private businesses, that means employers. Then also about 27% or 28% is actually paid by private, individual people. Then also there is about 6% there is about other private revenues are there. Then federal government spends about 27.6% of the healthcare dollars, funds about 27% of the federal from the healthcare dollars. Then state and local governments actually sponsor about 17% of the healthcare dollars. So that's how we see it. Then how the healthcare dollars are spent. If you look at US healthcare dollars, we see that there's a huge amount of money spent in healthcare. So you could actually see that hospitals take about 14% of that dollar amount. Then about, another 25% is spent in, physicians and clinics. Then about 12% is spent in nursing homes. Then there are about 6% is spent in other areas, and 6% is again spent on dental, and 5% is also, 6% is spent on another nursing homes, and those are some of the smaller amounts spent in other areas too. Then one of the unique features, if you look at our US healthcare, is that if you, the Medicare population, if you look at the total amount of Medicare population, there is about 24% of the people over the age of 80 are of the Medicare population. So that means that 24% of the whole Medicare population is above the age of 80. But the interesting fact is that the share of spending, that 24% actually consumes about 33% of the whole Medicare dollars. So you can actually see that as there are people when they get to a certain age, they actually utilize healthcare more often. So similarly, you could actually see that about 32% of the Medicare population between 70 to 79 uses about 30%, and again 65 to 69, which is about 26%, then spends about 15% of the Medicare dollars. So the challenge with the US Medicare, the health system, is that as people are aging and as the geriatric population is increasing, as the people are living more, they are actually utilizing healthcare dollars more and more often. Now, Dr. John talked about, about the utilization of healthcare dollars in different countries. As you can see that about 17% of the GDP is spent on healthcare dollars in US, which is way higher than so much of the other advanced countries. Now, when I talk about what are some of the advantages and what are some of the benefits of the US healthcare, these are some of the components I would like to discuss about. There is safe care is provided, then there is timely, then there is the effective care, efficient, equitable, and patient-centered. Then when you talk about, the safe care, the mortality for cancers has been falling for US population, but some of the other diagnoses, it is higher than comparable. So the advances in the cancer treatment has been progressing very well in US care. Then US also excels in the preventative measures, including flu vaccinations and breast screenings also, breast cancer screening also. Then US have also highest average in 5-year survival rate for breast cancer and some of the cervical cancer and things like that too. Then 30-day mortality for heart attacks and strokes are lower in the US compared to the other countries. Post-operative sepsis is less common in the US compared to the other countries. So there are actually, providing safe care. But again, I am not boasting about US health in all the aspects, but there are also some areas we have challenges too. Then this is another interesting slide, which you can actually see that the wait time, the timely care is important for US healthcare recipients. So in 2012 annual survey, the median wait time to see a healthcare provider in an ED was approximately, which is very unique to US healthcare. And when you compare to a lot of the advanced countries, it is way higher than the US ED wait times. For admitted patients, the median wait time, length of stay in an ED was more than 4 hours, approximately 1/3 of which was accounted for boarding time. Then another one of the other things, I want to show it in the graph is that this is a graph which actually shows the wait time for if you have to get an elective knee surgery, as some of the other people are actually looking at some of those things. There is a high wait time for elective surgeries in universal healthcare compared to US, which you can actually get in about few days. Then effective care is also one of the other part of it. Evidence-based practice is very common in the United States because of the scientific and research advances some of the hospitals and some of the physicians have created. Then there is also scientific resource centers provide scientific support for the US healthcare. Then there are a lot of patient registries and clinical trials happening in US, which help the researchers and even patients to register themselves for clinical trials and get those advanced kind of treatments for patients. Then there is one of the other important factors is the patient-centered care. Patient-centered care actually promotes patients to be the active in consultation with the physicians, and also the century-long physician-dominated dialogues are also slowly slowing down, and actually it encourages the patients to be the main participant in the care of the patient. Then, as you have seen in several other, when you look at US, you can actually see that choice and technology is very important in the US healthcare. US has actually ranked first for choice, driven by the American world leading access to new technologies and growing role of choice of private health coverage. This is very important for many of the US healthcare providers, because we are the ones who are actually advancing medicine and actually science and technology in medicine. Because you could actually look at a lot of the researches published, and also you can actually see that there is an increased push for new drugs and medical devices in US also. US also is actually ranked fourth in research and development expenditure in per capita. So you could actually see that a lot of the advances in medicine are coming from the United States of America. So then the other thing is that the innovations in care, these are a limited number of few of the list in innovations in care. The next generation sequencing, application of genetic sequencing to identify the risk. Because one of the major things is that if you have actually do genetic sequencing for people, you could actually identify what are the chances of you getting cancer or some of the other kind of chronic diseases and things like that too. Then 3D printing devices, which creates advances in and also customized medical technology products, which you can actually build new organs or make new organs based on 3D print device technology. Then one of the other technology we can actually see is that immunotherapy. There are so much more changes and advances made in the immunotherapy in treatment of so many other diseases also. Artificial intelligence is being utilized for the care of the patients. Then biosensors and trackers, technology-enabled activity trackers and monitors, because now we could actually see that because of that, a lot of patients can be taken care at their homes because of these advanced technology. Then convenient care is one of the other things which is happening in the United States, which is the retail clinics and urgent care, which is actually being provided at the convenience of the people. So they are making it easier for the patients to get care. With that, I want to conclude, though it is expensive to get healthcare, that some of the quality indicators and access to healthcare is much better in the United States with the current health system. So I want to stop by saying that US provide the best care, though there are some challenges with some of the quality indicators, but I think at this time, people are actually wanting to keep this system and getting this care what they receive in the United States. With that, I will turn back to Diana. Thank you.
Thank you, Mr. Kottoor, for presenting your views on the pros of universal healthcare. So we've heard about what is universal healthcare. We've heard this history here and the pros of it. So let's go ahead and take it to the other side now. Let's hear about the cons of universal healthcare and get a balanced perspective on this very meaty topic. To share about that, we have our third and final speaker tonight, Mr. Saju George. Mr. George is the Chief Executive Officer of Garden City Hospital and the Chief Executive Officer for Region 5 of Prime Healthcare. In his role, Mr. George oversees Prime Healthcare's hospitals, medical groups, and outpatient locations in Michigan. He's held various leadership positions within nonprofit and for-profit health systems. Prior to joining Garden City Hospital, he served at Ascension Health, St. Mary's, and St. Joseph Health System. Please help me in welcoming Mr. Saju George.
Thank you, Diana, for that generous introduction. Let me also express my gratitude to Detroit Debate Club for organizing this discussion and inviting me to be a participant. And I wish all the success for your continued success in your mission. The healthcare reform has been an ongoing debate in the US for decades. And for the two terms that is commonly seen used is universal healthcare coverage and single payer system. As Dr. John expressed before, though they're not the same, sometimes it is interchangeably used. For a few minutes, I would like to review the challenges of American healthcare system and try to unpack some of the complexities of adapting a universal healthcare system. Oops. I'm sorry, I'm trying to share my slide. Thank you.
Yep, I can see it now.
Sean, I'm not sure. I'm not able to move the slides.
Oh, okay. Do you want me to send mine and just, I can share my screen if you want.
Can I try it one more time?
Yeah, go ahead, give it a shot.
Yeah, I don't think I'm not successful.
Okay, no problem. Let me queue it up and just give me a second.
Oh, Tom, I think I got it.
You got it? All right, cool.
So thank you. So let's try to put a framework on what we are trying to before we get into discussing universal healthcare. And Mr. Kottoor already discussed this, so I'm not going to spend much time. In a sense, we have in the US a trifecta effect of high cost, unequal access, and often below average outcomes, as we heard before. We spend about 17% of our GDP in 2020 for healthcare, and our per capita expense is about 11,000, which is almost double than any other developed countries in healthcare. It's also true in healthcare in the US, we have the 80-20 rule, meaning about 20% of the population uses 80% of the healthcare spend. In addition, it is also proven that 1% of the insured population consumes about 30% of the cost. Yet, about 27 million people, and it's about 9% of our population, is uninsured. And healthcare is the major cause of bankruptcies in Michigan, in the United States, with 1 in every 3rd bankruptcy has something to do with healthcare cost. Now, when we look at despite the high expenditure, we have poor population health outcomes as listed here. Although the equality is one of our national values, we can't ignore the inequality that is part of our American fabric. To make things complicated in healthcare, the healthcare inequality is tied up with other social problems like disparities in income, education, housing, race, gender, and even geography. And to some extent, like Dr. John described before, irrespective of how good our healthcare services is, there is an impact on population health based on these factors. The main drivers of healthcare spend in the US, if you look at it, is a trifecta effect. High cost of salaries of providers, the pharmaceutical expenses, the medical devices, and the administrative cost. Here in US, we spend almost 3 times more in administrative costs than other developed countries. And our pharmaceutical expenses is also almost as 3 times as other developed nations. It is also important to note that US produces the maximum number of new drugs. So we do spend a lot of money in research and development of new technologies and cutting edge resources. However, there is also a significant component of cost that is related to medical waste. Often that is avoidable, either because from the overutilization of resources or costs related to lack of interoperability, that what we call it as duplication of resources just from provider to provider, because they don't have the ability to check and verify what was being done earlier. It's also true lack of price transparency in our system and poor consumer accountability are also factors that impact high cost in US. The true white elephant in this discussion is the American expectations. You know, we as Americans want the best and we want it now, and it leads to a behavior that we can't take nothing less than what we expect and when we expect and how we expect, and that trickles down to an American culture. Now, when you look at factors that shapes the American system, we have to, as Mr. Kottoor expressed before, we have to understand factors like history, our politics, our economics, and the culture influences the health policy, and the policy then drives the healthcare system, and then that leads into performance, often we see as the end outcome. The capitalist society like ours, often we don't even want to think about anything other than free market ideas. So even though free market ideas have not so far helped in curtailing cost, we are being pretty impartial in our views, and we stick with our history and ideology from the past. It is also true to note that we have left our partisan lenses to shape decision-making as opposed to making more evidence-based assessment of our risk and trade-offs in making healthcare choices. And it is true even to the last election and the recent events that unfolded in our country. Now, let's get into what is universal healthcare. World Health Organization defines universal health as everyone has access to good health without suffering financial hardship. The key here is universality, good health, and affordability. Now let's look at what is universal coverage, the terms that is often being used in plurality. Universal coverage is where every individual has a coverage. This can be accomplished by the government, by the healthcare system, by private, or a combination of the two. In a single payer system is where the government is paying for healthcare, and usually the money is collected through tax system. There are many countries, like Dr. John noted earlier, that uses the single payer system. Now, socialized medicine, like Mr. Kottoor mentioned before, we are so antagonistic even to talk about it. It's essentially a step up from a single payer system, where in a socialized medicine, the government not only covers for healthcare, but operates the hospitals and owns this entire network or the supply chain to provide the service, similar to UK, as we heard. Now, the reason I bring these back here is the irony is we have all these systems in US as it stands. Now, think about it. If you look at Medicare, Medicare is run by the government. pay into it. So it's nothing but a single payer system for a defined group of people. You can also argue that is a universal coverage for that defined group. Now, Veterans Health is also a single payer system that we have. The government pays and covers for all veterans. Now, the veterans healthcare can also be called as socialized medicine because not only it is covered by a single payer, it is provided through the infrastructure built by the government. So in a sense, what we have today is a patchwork of systems that is both public and private, as we heard before. And despite of all that, we still have 27 million people that is uninsured, even though it is significantly less than the 47 million that was uninsured before ACA came into effect. Still, we have a long way to go. Now, the question comes to why not then we adopt universal healthcare system? I would like to turn the coin and look at that from the perspective, from the other side, and looking from the outcomes perspective. If we had universal healthcare, what it would have looked like, and what will the outcome would look like. So the graph here shows that the most common argument for not having universal healthcare often is to say that it is very expensive. If you have to cover 27 million more people, who is going to pay for it and how are you going to pay for it, right? So the graph on the left, in a sense, shows that the growth in healthcare, which is the blue indicator, is about 2.5% more than the GDP since 1960s. In 1940, 1935, when Medicare, Social Security came into act, we were spending about 4.5% of our GDP. And since then, we have our rate of growth of healthcare spend has been far exceeding the rate of growth of GDP. Now, the graph on the right shows, it's a graph by the Congressional Business Office that shows that if we adopt a single payer system today, and the weighted average of how much more that we have to spend in order to cover the existing group of the population that we serve, which again shows that it goes from weighted average of 92 to up to 133. So there is a significant financial impact by adopting the system, at least in the short term, for a period of 10 years. The coupled with this is the impact of the deficit. In 2021, the CBO again projects our deficit as $2.3 trillion. And we are projected to average about $1.2 trillion in deficit for the next 10 years by CBO. So when you look at that, it truly paints a picture. Yes, it is nice to have full coverage, but we don't have the resources to cover for these added exposure without making some change in the equation. Now, this graph shows the federal tax history and how it compared to other countries. Historically, US federal tax accounted for about 25% of our GDP. Now, the CBO estimates if you have to go to a single payer system or universal coverage, that tax bracket has to raise up to 32% to sustain this model. So that's the real dilemma. Are we willing to increase our tax bracket to increase the revenue? Or are we willing to reduce the cost by adjusting all the determinants that we talked about before? Now, either way, it has a determinant, it is not determinant to the well-being of the community, because it has a direct effect on the economy as well as the providers as it stands. Now, the graph on the right shows that the impact of the cuts for hospitals since the last 10 years. Now, Mr. Kottoor mentioned that 40% in the graph that he shared before showed that 40% of US healthcare expenses comes from hospitals. And there is about another 25% of the total spend is through pharmaceuticals. Now, what if we reduce the payment to the hospitals? And that's what we are seeing here is already, if you look at the last decade, there has been a tremendous rate of consolidation and hospital closures in the last decade. And if we further push this cannon down, that could have significant negative impact, like having less acute care beds and resources to take care of our community. The second argument against universal healthcare is the conundrum of quality over quantity. Although overall the quality of care in US is not as superior as other countries, we do excel in many areas. For example, stroke and heart attacks, and we are our performance is in the best in the world. So if we have to put rail guards or guardrails on the utilization of services in order to increase the access of coverage, that could impact on some quality and efficiency, as we heard before. This could come in terms of having limitations to having access to certain services, or it could be not having access to latest treatments or drugs that we have the liberty and choice that we have today. Now, the argument again continues. Right now, if you look at our patient satisfaction globally, we enjoy the benefit of higher satisfaction than most developed countries. So the challenge then becomes, if we curtail on the services, the quality can go down, and so does the patient satisfaction. In the UK, as Dr. John was referring, sometimes it takes longer for UK and Canada to get even elective procedures. And as well as there are limitations in certain diagnostics, whether it is MRI, CT, or PET scan, that we literally can walk in and get that service today. Whereas if you go to a model with some guardrails, it may limit our ability to have that access at our fingertip. Then it leads to the fundamental challenge in adopting healthcare is beyond economics. Truly, it is a cultural impact in my mind. For me, there is nothing more American than baseball and our freedom of speech and choice, and our passion to keep our freedom of speech and choice. So we often make sacrifices to uphold that choice, and we want the choice to make the decision when we want, how we want, and where we want it. And for that, we are ready to sacrifice other benefits. The fundamental question here comes again is whether healthcare is a right or a privilege. And if you look for the last decade, we had been as a society deadlocked or in making a decision whether it is our right or privilege. We are split equally in letting lose the control and having somebody else impose the standards or resources on us. So our political and cultural gridlock is one of the most challenging the limitations that we have in adopting universal healthcare system. Now, I would like to end by saying despite poor population health outcomes, the quality of healthcare delivery, especially when people are sick, is very high in US. So changing from the present model to a universal healthcare without addressing the determinants of healthcare and the cost components that can be controlled and the outcomes that can be improved could cause more disruption than having benefit to change our system. With that, I would like to pass it back to Diana. Thank you.
Okay, excellent. Thank you so much, Mr. George. So our expert speakers have put it all out there for you. What is universal healthcare? What are its pros? And just now, what are its cons? There's a lot of information, but I think you've got a pretty solid framework. And now we want to hear your questions. And it is time for Q&A. As a reminder to our attendees, if you have a question for any one of our speakers, they're all going to come back onto the screen. Go ahead and enter it into the chat box. Or you can raise your hand to ask it live by clicking on the participant icon on your bottom menu. The instructions are also here on the screen, so don't be shy and go ahead and ask your questions. We've got a little bit of time left, so we definitely want to get to as much as we can. The first question I want to ask is, clearly, if we were to make a change into universal healthcare in the United States, a significant amount of reform is required. Is there a model from a different country with similar parameters that could possibly translate well into the US? And I'm opening that up to any one of our three speakers who would like to comment.
When we look at universal model, what resonates for me at least is a model that is presently utilized in France. France is rated to have the best healthcare outcome among the developed nations. And what resonates to us is France has a mixture of private and public funded health system. And where you still have the choice, but you have a mixture of public and private partnership to provide universal healthcare. So if I have to pick a model that that I would recommend to consider US leaning to, France comes in my mind.
Diana, I would also say that if we were actually going to go for a universal health system, we already have a model that we are actually utilizing Medicare as a model. So if we can actually expand Medicare, to all, so that will be another model we could explore. But the challenge is that, as Saju was mentioning earlier, the tax burden on the people. So I think I'm not sure whether, because of our political and cultural kind of background, we are ready to do that kind of thing.
Right, that makes sense. I think that tax burden and the fear of change is certainly a pretty big prohibiting factor for many people in the United States. In addition to that fear of change, are there any additional barriers that you think that people in the United States face when simply learning about universal healthcare or being able to adapt into this kind of a system?
There is also challenges with people's choices too. I mean, I think people want to choose what they want for their health. I mean, they have that ability to do. Once you have the universal healthcare, I think the challenge is that everybody has insurances. Then you are actually asked to do, they probably have a particular PCP or a hospital of choice they have to affiliate with. Those are some challenges for the people. I think those are some of the challenges people might face in terms of choices.
I would also like to add, we are heavily focused on the illness rather than on prevention. So that's a huge gap as a nation that we have. We don't have the infrastructure. We don't have the focus on getting into prevention and primary care. We spend all of our dollars in the back end. So shifting that paradigm is also very critical and a big challenge for us to cross.
I would say the providers are paid on the things that they do, right? So the more tests the hospital does, or the more people or specialist person sees, probably they'll make more money. So it's sort of difficult. That is just driving up the cost, even if it's not essential. So that if you have, for example, if I'm saying is that if you have a CT scan and it can give you the information, why would you then need a MRI, or why would you need a PET scan or something which will cost like 5 times or 10 times the cost in every patient? So that if it's really necessary, it should be available. But the way the system is now, there is no penalty for ordering extra tests. So that everybody is practicing being safe. So they don't want to miss anything. So even if there is 1 in 100 chance of missing something, they do it, right? So that in older times, the physician would examine the patient. Now all they go by is the ultrasound and the CAT scan and the blood work, that kind of thing.
Dr. John, you're absolutely right, and that is the lack of interoperability and coupled with the American desire to have the choice and freedom and the right to get what they think is the best drives that further. But along with that is the concern about liability and malpractice in the U.S. A lot of that behavior of cost and utilization historically has been driven because of the liability concerns and malpractice concerns by the provider as a group.
Okay, we have a question from our audience from Josh Chaco. And Josh, go ahead and unmute yourself, and we'd like you to go ahead and contribute to the conversation.
Hi. First of all, can everyone hear me?
Yes, we can hear you.
Okay. Yeah. So this question is directed towards Mr. Saju George. So you cited in your presentation that one of your objections for universal healthcare is, how much it would cost the taxpayers and how it would increase cost of healthcare spending. What would you say to the argument that implementing a single payer system would actually lower healthcare spending? There was a study proposed by a medical journal called the PLOS Medicine that says that adopting a single payer system would drive administrative costs down by $600 million. So what's your response to that assertion?
Thank you, Josh, for the question. As very appropriately stated, that is the dichotomy of the American view, right? Part of it because of the capitalist society and where we want choice and where we feel like we don't want to look at we want choice to see how we want to curtail it. And so having a single payer system seems to be an imposition that you have to take that without a choice. And as you saw in the graph there, the Gallup poll for decades have shown that we as a society is very divided on it. I do agree with you. I mean, as an individual and as a consumer and a citizen, I am pro for universal healthcare. However, the argument that it will cost money in the front end before we can flatten the curve is also true. And there has to be some give and take. You cannot keep the equation same and cover 27 million more people. There has to be some curtails in terms of what is covered, and rightfully so in many cases. Right now, somebody has a back pain, and what they do, we wanted to go and get an MRI first because we have the choice and we have the right to do so, right? So we do not look at other alternatives like what Dr. John was mentioning before in his presentation. We jump straight into the best and what we think is right. So there in long run, and also, like you said, the administrative cost is significant in the US. And primarily that is driven from the private insurance model. Because as you heard, almost 68% of the healthcare spend is through the private insurance or private payers model. I mean, their concept is they have to make a profit too. They are a profitable entity, right? They are not nonprofit willing to do a service. This is a business for them. So Medicare, the traditional Medicare, if you run that program and cover everybody, then you have to make some rail guards and adjustments to make sure that we can spread the wealth. Or we have to go and say, for the private insurers, we have to shift that paradigm more into a government-run program, which again is a dilemma because we want our choice, and that is against the free market agenda that we have seen for decades. I hope I answered your question. It's a long-winded, rounded answer for a straight question.
Okay, thank you for that. We've got another question here from Jamon Jacob, who has raised his hand. So we're going to ask you to unmute, and please go ahead and ask your question.
So this question is based on all three of your presentation. We heard from Dr. John that we in US spend 17% of the GDP, and from Joseph Kottoor, we heard that there is 27 million are uninsured, and Saju said the elephant in the room is that are we willing to raise our, as far as at least I am concerned, from our current tax bracket from 25% to 32% to cover those uninsured people. Also, we want to improve our healthcare and quality indicators. So my question is, do we can at least provide preventive care for all the population, at least a modified version of Medicare for all, to at least for a preventive care, so that it can be included as a healthcare education to prevent morbid obesity or to prevent diabetes, something like that, a limited coverage for all the population who are all uninsured, so that at the back end, there will be lesser cost at the end. Thank you. That's my question. Question can be answered any of you presenters.
I'll take a little bit stab on that one. So, Jaymon, thank you for that question. I think one of the things what currently a lot of the, payers, insurance people are actually making some strides for preventative care. And they are also looking to, for example, diabetic education. Now that is becoming a little bit more of a standard of care in chronic diabetic management. So there is some movement in that. But again, you got to remember that, our system is set up in a fee for service. I mean, if we are going to provide that service, I think that need to be get paid. So there was a lack of, payment for so much of the preventative care. That is one of the reasons actually we have a lot of challenges with, disease management, especially with the chronic disease management and issues like that. But I think that pendulum is swinging a little bit onto the right, I would say, because they identified there are some benefits to that in terms of managing these diseases and things like that. So I think there is going to be some changes, but I don't know how soon we are going to see all those changes till there is some commitment from the payers, the insurance payers, that those preventative care is going to be get paid by either by the insurances or by the physicians or other providers. I think that is when it is going to happen.
I would like to add to what Mr. Kottoor said. In some ways, COVID turned out to be a catalyst in shifting that paradigm as well. So if you look at last year, 2020, all of a sudden we see that elective procedures and emergent procedures have fallen off the cliff. So what happened to the heart attacks and strokes and all the hips and knee replacement, other things that we used to do all along? So people are forced to think about alternatives and are fear, either because of fear or the lack of appetite to expose themselves. That I believe will turn to be a catalyst in shifting the paradigm, along with the telemedicine introduction, that we will see more efforts and by payers as well supporting these initiatives as we go forward.
Okay, great. Thank you. We've got a question from our audience, not on the video. And even though the US has advanced innovations in our medical field, the life expectancy in our country is lower than in many other countries. How is this happening? And if we were to change or not change, how does universal healthcare play a role in that?
I think I can, start answering that question, because now currently our life expectancy is at 79 years of age, which is lower than many of the advanced countries. One of the reasons I see, the main reason is that if you look at the homicide rate in the United States, it is much higher than some of the other countries. When you compare the latest, data, you can see that there is a homicide, 6 homicides are happening for the 100,000 people. And when you compare that number to Canada, it's about 1.5 people for 100,000 people. So that is the kind of difference you actually see. That is actually, so there are issues related to the culture, the issues related to diet, and also the culture of the people, the diet of the people, the environment of the communities here in the United States. All those actually play into the life expectancy of a country. Then, especially when you look at our smoking rates, the deaths because of the smoking rate, deaths from the obesity, or then opioid overdose, suicide, road accidents, industrial accident, all that actually plays into the reasons why our our mortality or our life expectancy is lower than some of the other compared countries. So I think that is one of the reasons. But again, US is making huge strides into improving the life expectancy of the people in the United States. If you compare that in year 1880, our life expectancy of the United States was about 39 years of age. Now it is at 79 in 2021. So that's the kind of changes you are actually seeing. But I would strongly suggest that when there is more chronic disease management, when there is more awareness among the people about the managing diseases or smoking cessation, those kind of things happen, the life expectancy will be up.
I would say it also has to do with 10 to 20% of the population that has no coverage, and then there will be another particular percentage with less coverage who don't have the luxury of all these advances. So the advances are only benefiting maybe the wealthier half, or the half of the population with good insurance.
Agreed.
I agree with both of your thought process. To add to that, life expectancy is directly correlated to socioeconomic factors and prevention, as we discussed before. So universal healthcare, I do agree that could impact positively to further improve life expectancy by changing those two indicators.
Okay, great. Yeah, there's so many factors that do contribute towards that rate, and so thank you all for your answer on that. We've got a question and comment here from our audience. Mr. Mathews Travel, if you'd like to go ahead and unmute yourself.
Hello, everybody. Our distinguished presenters, Dr. John Mathews, Dr. Josh Kottoor, and Saju George. You guys did a wonderful job presenting all the facts and figures about the universal healthcare, especially the history. The history of healthcare in the US and all. Most of the people do not know where it started and what it was, and where it stands right now. So it was very educative and very informative. Thank you for that. One small question only I have. One is, see, in US, there are plenty of people, those who do not have any insurance, any coverage. There is no job, there is no income, nothing. Those such kind of people, if they are sick, how we are going to deal with it? And presently, there are a lot of complications. I know that, but is there any suggestions, any viable way we can deal with them or help them, get them medical help? What is the suggestions? You guys are the experts in that field, so I would like to know whether from Saju or Josh Kottoor. Thank you.
So it is seems like a small, simple question, but it's a very complicated question. In the sense, first of all, let me state some facts. In the US, irrespective of whether you're uninsured or whether you are an illegal alien, everybody is treated equally in terms of your emergent need. So anybody who has an emergent disease, you walk into any hospital emergency room, by law, you are covered fully up to you're stabilized and your emergency is covered. That's number one. Number two, I wanted to refer to Medicaid. Medicaid is it's a state-funded program supported with the help of federal funding, right? So the states had the ability to expand Medicaid with the ACA, and we saw the partition divide in that, meaning many of the Republican states at the time of President Obama's introduction of ACA chose not to expand Medicaid. But let's say in Michigan, we are a Medicaid expanded state. That means anybody at 133% of the poverty line is covered with an insurance. What we see day to day is people are still ignorant in 2021. They come into the hospital thinking that they don't have insurance or they're not eligible for insurance. In fact, most of them will be qualified. Again, if you fall within 133% of the poverty line. You need not have to be below, it can be above up to 133%. So those are the two things that I would like to say that is available today in our present system. Now, the question then further continues to say, okay, what happens if you're over the 133 threshold, or if you're an undocumented alien, you fall between those categories. That is the challenge of the present system, right? We do not have a safety net structure that is funded or supported by the government to keep them healthy and out of the hospital. So the one of the reasons why the healthcare cost is going up, like we discussed before, is that the 80-20 rule is because there are people who have no insurance or assume that they don't have insurance. They don't seek care, and by the time they come to get care, by necessity, they are so sick that we end up spending enormous amount of resources. So there is a public awareness campaign that is truly needed, even in this era, to make sure we spread the awareness that there are a lot of resources available for us to execute.
I agree.
So I have a question for Jose or Saju. This is something to do with the cost of new drugs. So whenever any innovative treatments or new drugs are made, in most countries in Europe, there is some sort of price control. But in US, I understand that the pharmaceutical company can charge whatever the market will bear. So if they feel that they sell it for $6,000 a month, they can charge that. If they think they can sell it for $10,000 a month, they can charge that. Is this not driving up much of the costs of therapy?
I totally agree with that. The challenge, if you ask some of the drug companies, what they say is that there are patent laws actually which controls, the cost of those things, cost of the newer drugs to be stabilized, and they can actually set that price for a certain time limit. One of the things what they argue is that when you actually look at research and development, when you look at the whole numbers of drugs they are actually looking to develop and research, only about 10 or 15% of them actually come to fruition, and other 90 or 85% doesn't actually make it to any of the market. So they are justifying their cost in the increased cost and the limitation in their patent kind of cost, because of these kind of costs and things like that too. So they are actually protected. And again, one of the things, Dr. John, one of the things, again, it goes back to our capitalistic thinking and also our thinking of our people here. I think that's one of the things, because it is actually, they are saying that, okay, whoever gets into the game first, they will win and they have the control over the drugs. And I totally agree with that. The cost of the healthcare is actually primarily, driven higher to a point because of the cost of the drugs.
No, because one of the things you must realize is the same drugs, if they sell it in UK or France or Australia or New Zealand, will be probably half the price that they charge in the US.
Agreed. I agree.
Correct. And echoing further on that sentiment, lack of price transparency is a huge issue in the US, and it continues to be even today, even though we are chipping slowly into it. Effective this year, Jan of 2021, the hospitals are required to publish pricing for 13 elective procedures as a first step. And there are gradual steps that is put in place. So this lack of transparency coupled with lack of accountability from the consumers fueled these free market thought process, where we can do whatever we can during that period of time and blame it on R&D for the things that Mr. Kottoor mentioned. That's one of the barriers that we have to break in order to curtail the cost to get us moving forward.
Excellent. Okay, so we have so much information here that all three of you presented, and we've got one last question from our audience, and it's from Josh Chaco. So if you could go ahead and ask your last question. We want to be mindful of our time, but also get as much information as we can out of all of you. So go ahead, Josh.
Okay, yeah, hi. This is a broad question relatively. So how would a universal system, before it was implemented, how would it handle medical procedures that a large portion of the population might find morally objectionable? So like in the US, we have what's called the Hyde Amendment, which bars federal funding of abortion. So under a universal system, how would a procedure like that, or another controversial procedure like euthanasia or sex reassignment surgeries, like how would that be handled? Like would it be funded by the government, or would it be an elective procedure? So, and I direct that to all three of you.
Maybe I can take a stab at it. First, thank you again for the question. So again, the different ways to skin it, right? It can be through some rail guards, or what could be argued as rationing, by saying that certain types of procedures are not going to be covered. Like Dr. John said, the situation in Canada, that X amount of things are outside of the coverage of universal healthcare, and you have the choice either to pay that out of pocket or cover that through private insurance. So that's one way to look at it. The other way to look at it is as in France, like the government covers X percentage of the cost, and the remaining, so in their case, I believe it's about 80% of all the cost. The remaining 20% is your expense, and you could again choose to cover that through supplemental insurance or other plans. So there's the ways to skin this.
I mean, in Canada, certain cosmetic procedures are not covered, so that's completely outside the system. But things like euthanasia, abortion, and all, they are paid for by the system, but the facilities are, the doctors, there may be a few of them doing it, but not everybody will offer it. So it's available, but less accessible.
Okay, I think we can agree that there is just so much and so many different perspectives regarding this and scenarios that we could all ask, and we could probably talk about this for a very, very long time. But we've already gone a little bit past our allotted time frame. So that's going to be the last question that we have for tonight. And a huge thank you to each of our speakers here today. Dr. John Mathews, Mr. Jos Kottoor, and Mr. Saju George. You have all shared your time and expertise with us here today, and the Debate Club of Detroit appreciates you and thanks you so much. Thank all of you who are our attendees for joining us and engaging with us. We very much appreciate your evening with us, and I think I can confidently say that we've all walked away from tonight having learned something new, and we've got plenty more to think about. If you'd like to keep up with upcoming events hosted by the Debate Club of Detroit, please go ahead and follow us on Facebook. And you can do that at facebook.com and just search for Debate Club Detroit. To close out our event, I'd like to welcome Ms. Mary Sebastian to share some of her final thoughts. And thank you all so much.
Thank you.
Respected speakers, organizers, and dear audience. Saying thank you that's my duty today. Is not just a gesture of gratitude, it is a sign of spirituality. In that way, I'm really privileged and honored to express my thank you to all these three great speakers who made this event a grand success. Dr. John Mathews, he's a close friend of mine for more than 20 plus years. If I describe him, he's a very humble, simple, very learned person who is a dedicated doctor. And he's a very trustworthy friend. He actually gave the foundation for today's event by sharing his great wisdom with us. I sincerely thank Dr. John Mathews for accepting our invitation and sharing his wisdom with us. Thank you, Dr. John Mathews. Yeah, I need a clap. Even though I don't know Dr. Jose Kottoor personally, I heard a lot about him from his own brother, his sister-in-law, and their families. What I heard is he's a very person with lots of capabilities, administration capabilities, organization skills. He led many organizations, and he's a very knowledgeable person. From his talk today, we know that he was sharing all the important information regarding the healthcare system, its development, how it is done here in US. He also accepted our invitation without any hesitation. We are very thankful to you, our heartful thank you to you.
Thank you.
Mr. Jose. Even though I don't know Mr. Saju George personally, we have so many common friends. And they described you as a very successful person at a very young age. And your leadership is so great. You are having so many, you are at a very higher position right now. In spite of all those busy schedule and life, you are actually a person with so much of a kind heart. You are actually conducted many charity events and collected money to help those communities are in need. And from his talk, we know, especially I like the part where the difficulties in implementing universal healthcare system in the USA. Thank you very much for sharing your insights into this particular evening with your knowledge and wisdom. Thank you, Mr. Saju George.
Thank you.
I would like to thank the organizers, Mr. Mathews Chirivil, Mr. Thomas Kartanal, and especially Mr. Jaimon Jacob. They were actually planning for at least 2 months to bring this event into a successful, into this today. And thank you very much for organizing this beautiful, wonderful event. The logistics and the technical backbone was actually provided by Sean Kartanal. It was done perfectly well today. He was supported by a team of members like Melvin Manuel, Justin Valleparambil, and Josh Chaco. The event was done perfectly well under their leadership, under their guidance. Everything was, this is done very well. And I don't have to mention Miss Diana Chervil. This event is so colorful with her effortless efforts. Thank you, Diana, for making this event a grand celebration. Thank you very much. Thank you, and not last but not least, but our audience. They made this day the most successful by their presence and their participation. Thank you for making this event a grand success, everybody. Thank you very much. Thank you.
Thank you for having me.
Thank you for having us.
Thank you very much.
Thank you.
And with that, thank you all for being here and enjoy your evening. And the Debate Club of Detroit hopes to see you again soon. Good night.
Good night.
Good night. Thank you.
Good night.
Good night.
Thank you all.